do for next year? It's like we were, oh, perfect. Thank you, Dr. Jordan. And so I was like, at a fork in the road for me. I was like, do I go be an audiologist because I'm, so like passionate about hearing loss, or do I be a speech pathologist? And we were already doing clinic in our undergrad. And I went and talked to my audiology professor, and this was the beauty of going to a small private school. She got coffee with me a couple times, and she was like, listen, I've seen you in clinic, and I know that you are a gifted therapist and that you really like enjoy that ongoing therapy aspect. She's like, have you considered oral rehab as like a path? And I was like, I don't even know basically what you're talking about. And she kind of introduced me to auditory verbal therapy. And she said, I want you to go observe this auditory verbal therapist. And so she gave me this lady's number, and she worked out of her home. And I went to her home, and I watched her do a couple sessions with kids with cochlear implants. And she had like a game wall that was like floor to ceiling. And I was just absolutely enthralled. I was like, wow, this is what I want to do. So she's like, okay, for this path, you could do audiology and then AVT, or you could do speech pathology masters and then pursue your AVT certification. So I'll get into all that with you guys, but that's the path I ended up taking. So I went and got my master's at San Jose State. And then when I graduated, I also got I was able to be on this oral rehab grant while I was at San Jose State. It was all very serendipitous and meant to be. And I got on this grant and then was able to get like specific oral rehab placements. So I got to work at a cochlear implant school called Weingarten, and that's in the Bay Area. It was like very, very high level, amazing service and therapy and school that they do there. So I learned so much. Then I graduated from there, and there was like one position available for a CF, and a different girl ended up getting it. I was crushed. I was heartbroken, and I was like, okay, well now, the world is my oyster. Where do I want to be? As an SLP, I can get a job anywhere tomorrow. We're in such demand. And so I just like kind of closed my eyes and just saw myself at the beach. So I was like, screw it. Started looking up places in San Diego, and I took a job with EBS. They may have hit you guys up already, but I took a job with EBS working for a school district. And I was like, you know what? I'm just going to reach out and see if I can find any AVTs like in the area and just see if I can be mentored, see if I can like pick their brains and figure out how to get down this path. And so I found one on like LinkedIn, and she ended up, I reached out to her and I was like, hey, I got a job, I'm moving to San Diego. I would love to just pick your brain about AVT. And she had her own private practice, and then she worked at Rady Children's Hospital and started their program. And so I reached out to her, and she's like, hold that thought, I may have a job for you. And turns out like a week later, she's like, cancel your contract with EBS, like come work for us. And I got a job at Rady Children's Hospital doing AVT therapy right away under her mentorship. And then a couple of years later, got recruited back by my previous supervisor from that Weingarten Children's School, who also worked at Stanford. And that's when I started their program. That was like 3 years later, started their program at Stanford, as Dr. Jordan said. So I was the first SLP on staff in audiology, starting their oral rehab program. So that was a little bit of my journey. And I just feel like I got super lucky and lots of manifesting magic along the way. And so all that to say, I just want to encourage you guys, even though, you have this whole next year ahead of you. And I would just say to stay in the moment and enjoy it and trust that it's all going to work out. And even though you can't see like how it's all going to work out and all of the things that are going to come your way, just trust that if one door one door closes, that another one will open, and that you'll be completely taken care of, and it's all going to work out magically. And just trust and try and release any stress of the unknown, because it's going to work out really magically for you, I know. So all that being said, let's start the presentation. And And I want you guys to really feel free. I can't see any of your faces, so feel free and raise your hand or drop any questions in the chat or just comments. I'd love for this to be a little bit interactive, or just take yourself off mute. I totally don't mind. I would love any questions. So is there any questions right now as I go to share screen here? Okay. Here we go. Almost, you guys. There we are. Oops. I don't think that's the right thing. Nope, don't want to do that. I think it's slideshare. Sorry, guys. Come on, internet. Thank you for your patience. And Dr. Jordan, can you just pop off mute? How long do we have, or what time is our stop?
So technically it's till 7:15, but since this is the last class, I think we could probably all stay a little later, since really class is supposed to go to 8:10, but I calculated the hours and that was way too much work for the students for most weeks. This one, I might have people stay a little bit later. So how's an hour to 7:30 sound to you?
Okay, perfect. And I'll try and like hard stop presenting by 7:20, and then we can have a chat for like the last 10, if that sounds
And then we've
good.
got one question that's not exactly relevant, but where in San Diego are you now?
Oh yeah, okay. So yeah, I guess I should catch you up on like the
I guess not where, it is relevant because I assume Nadia means where are you working, not where are you currently living.
I do. I'm not
Well,
creepy.
I don't mind at all. Yeah, either way. So in 2020, so I went after I worked at Stanford, I got a job back at Rady Children's Hospital in San Diego. So I worked in children's hospitals for 7 years after grad school, and then I felt confident to start my own practice. I just kind of felt overworked, or burnt out, I should say, at Rady Children's, and so I decided to start my own practice. And from there, started my own practice called Children's Holistic Therapy. And the holistic is just because I really believe in like meditation and the power of like your breath and breathing, and I incorporate that in a lot of my sessions. I'm also Reiki certified, and that comes in handy with certain kiddos that I work with. And so that's always like at the parent's discretion if they want that incorporated in their session. But I see most of my kids virtually, and I see just one or two in person. And that I planned, so in 2020, it was February 2020 that I started my business, and guess what happened in February 2020? Anyway, so then we all went virtual, which was such a blessing. And because I was going to be driving, all over San Diego, and instead I can see kids all throughout the whole state of California. And I've gotten a lot of referrals like back from Stanford area and back from the schools that I used to work at. So it's really worked out that I see kids from there to like El Centro, which is a couple hours away. So I'm able to see them all virtually. And there's so much like efficacy and research that supports teletherapy, especially for AVT. And I will get into why that is. And then here's my contact info here. And then I have it on the last slide as well. And then you guys should have a copy of these slides as a PDF as well. So you'll have all of that at your fingertips. Let me see if I can make this go away. Okay. Alrighty. So I started Children's Holistic Therapy in 2020, went virtual, absolutely love working for myself. I started a YouTube channel, so you guys can check out some of my videos on there. This is my little baby Roxy, and that's my old office at Stanford, and she would come in as a little baby puppy. And then this is my mother, and that's her CI activation day. So it's a really, really special day for us. And here we go. Whoops. Well, okay. I just want to see if it's possible. Okay, now I can see you guys. Let me ask these questions, and if you guys don't mind raising your hand, so I just know a little bit about you guys. How many people, or how many of you think that you'll steer towards early intervention? Go ahead and raise your hands. Jillian, cool, I see ya. Awesome. Okay, how many people think you'll steer towards schools? School age. Anybody? Okay, how many people think you'll steer towards adults or hospital setting? Mucho. Nice. All right. See you guys. Perfect. Cool. Okay, thank you. How many people are interested in oral rehab or AVT specifically? Allie, cool. I see you. Nadia, awesome. Okay, perfect. And then how many of you have no clue? Or you're not sure yet? Thank you. I appreciate your honesty. Yes. Don't worry, you will figure it out. Don't worry. Okay, good. And then last question, how many of you know somebody with hearing loss personally? Oh wow, quite a few of you. Cool. Yes. Okay. Awesome. Yeah, so I'm going to be sharing like from my perspective, and I've told you about my mom now. So I yeah, I have not quite controversial opinions, but you'll hear it. You'll hear my opinions. Okay. So, here we go about certain things. All right. Thank you guys so much for sharing. Okay. So, based on what Dr. Jordan tells me, a lot of this will be review in the beginning. So, kind of the difference between an SLP and an AVT, there's a lot of overlap. So, like I said, you can be an SLP and then get your AVT certification on top of it. So, like bottom right, that's what my title looks like. And so I'm a CCC-SLP and also an LSLS Cert AVT. And so you know what an SLP does, and then an AVT on top of that, diagnosis and treat speech and language disorders caused specifically by hearing loss. There's specialized training, which is a 3 to 5 year certification. Mine took 5 years after your master's degree, and primarily specializes working with cochlear implants. And I also see AV Ed. A lot of teachers of the deaf will get that. Some audiologists have it as well, and there's just not that many of us. Okay, so yeah, just so you guys kind of have a breakdown. So this was 2018 numbers as of total in the world. So total SLPs, 168,000, 13,000 audiologists, and roughly 800 auditory verbal therapists. So looking at that pie graph there, we are a very slim portion. There are not a ton of certified professionals, which is, yeah, I'm the only one for like 30 miles in my area. All right. So how to become an AVT. So if you decide to jump on this bandwagon with me, it requires being under a mentor, so an actual certified AVT mentor for 3 to 5 years. So I've had 2 mentors. So I had one at Rady Children's Hospital and one when I worked at Stanford Children's. And then that was like not that big of a deal to have multiple mentors. You can find them on the AGBell website. So on the bottom here, agbellacademy.org is how you find and how you like learn about how to do it. So yeah, there's like a little bit here. So AG Bell, I go to their conferences every year. They're a really fantastic organization, but they're the ones that actually certify you as an AVT. It requires 900 clinical oral rehab hours that are signed off by your mentor, 20 mentored sessions, 10 observed sessions. So they observe you for 20 and give you a write up on your session. You observe them for 10. And then you have to do 70 hours of continuing education, blood, sweat, and tears, and then a 3-hour AVT exam. You have to write a paper and then get a couple letters of recommendation. I'm not trying to steer you away from it. I'm just letting you know it is a lot to get certified. But the good news is you can also start during your CFY. So if you work with kids with hearing loss in your CFY and your externships, log those hours because they count towards your 900 there. Okie doke. Any questions there? If there are, pop yourself off mute. Okay. All right.
Yeah,
Where
so
doesn't?
sorry, I have one
Oh,
question.
please. Yeah.
Um,
Please, please.
Is there, and I don't know if you're gonna mention this later, but is there a difference between like the AVT and an LSL certification?
The same, one and the same. So
Oh,
listening
they're
is
the same
focused.
thing. Okay.
Yeah. So it's LSLS Cert AVT. So listening and spoken language specialist, certified auditory verbal therapist. It's one and the same. I don't know why there's two different terms for it, but yeah, it's just like all one thing. Thank you for asking that, Nadia. Okie dokie. Here we go. All right. So where can we work? All these lovely places. We can work in a hospital. We can work in outpatient rehab, which I've worked in both of those. Now I work in private practice. You can work in a school, early intervention. I also work for an early intervention company. I do some contracting with them. And you can also work for a cochlear implant company, which is something that I'm considering because they need your expertise. Okay. Everybody knows what oral rehab is. Pop quiz. And if I had candy, I'd throw candy at you. What is the organ of hearing? Drop it in the chat.
I got it. Good job, Emily. The cochlea.
Yay! Wonderful. Well, okay, so that's like the technical organ, but like what's the true organ? Where do we actually hear? It's a trick question.
It's a trick question.
Anybody?
We have the brain, Megan.
Get it, Megan. Awesome. Candy for you. Okay. Yes, I've given these lectures in person and then I just throw candy at people.
Giving
Sometimes I hit you in the
digital
face.
candy in the chat.
Digital candy in the chat, please. Okay, yeah. So of course we the physical mechanism, you know how all that works. But I'll explain here on this next slide. Okay, so Carol Flexer is one of the gurus of AVT and oral rehab, and she says that the ears are the doorway to the brain. So, can you guess who solves the doorway problem? Which professional? Drop it in the chat. Come on, guys. Oh, thank you for giving that candy, Dr. Jordan. Okay, more candy on the line. Okay, who solves? Okay, good. ENT, who else? Who solves the doorway problem? So if the ears, you're not able to hear at the level of the ears. Yes, good, Nadia. Audiologists. So audiologists and ENTs are the doorway solvers. And then, so once the doors are open, thank you, Dr. Jordan. My candy giver. Okay. So I hope you guys are tracking your candy and like go give yourselves candy at the end of this. So the doorway solvers are the audiologists and ENTs. So once the doors are open, then who trains the brain? Who trains the brain how to interpret the sound? Yes, Elizabeth. Exactly. SLPs and AVTs. We are the trainers, and some audiologists do oral rehab. Or audiologists do oral rehab in almost every visit, but the SLPs are the ones like day in, week in, week out, like really digging in that training. So once you, for example, get a cochlear implant, then you really have to work up the auditory hierarchy to make sense of it. So, you get that electrical signal going, and the brain is like, this is gibberish, this is garbage. Usually in the beginning, and then some people get really lucky and can really make sense of it right away, but often it takes some weeks of training before they start to like make sense of speech at all. So that's a really important thing to remember. Also, I want to explain here really quick. So we've got the four lobes of the brain. We've got the frontal cortex, the parietal, the occipital, and the temporal lobe. Okay. So when a baby is born, it's really important to understand this, because this is what Carol Flexer and a lot of AVTs call a neurological emergency. And so, you know, the 136, is it still 136, Dr. Jordan, for
It is,
diagnosing?
yes.
Okay.
For,
Okay. Yeah.
newborn hearing screening standards, yes.
Okay. Okay. And y'all are familiar with what I mean when I say 136. Throw up your hands if you know what we're talking about.
I hope they are.
Good. Thank you. Okay. Okay, cool. So it's a neurological emergency. Super, super important to get that doorway, you know, solved as soon as possible, because by the time a baby is born, they're actually 20 weeks behind. At 20 weeks in the gestation in the womb, they can start to hear, and their cochleas are fully developed and actually full size, that they're going to be their whole life. And if they are not hearing, if they're profoundly deaf or even moderate to severe, moderate to profound, then they're missing out on valuable auditory cortex developmental time. By the time that newborn babies are born, they've done studies that they can recognize their familiar caregiver's voice. They can recognize familiar songs and familiar books. So they like show a different response to when those familiar ones are shown to them versus unfamiliar. So they're like already have this ability to distinguish and discriminate familiar versus unfamiliar voices and sounds. So really important to know. So by the time they're born, they're technically behind, right? The other thing is important to know is, so hearing happens in your temporal lobe. That's where your primary auditory cortex is. Now, when we don't have sound coming in, that cortex does not get developed. And you know that age-old saying of when one sense goes, the others get stronger. So think about if you're not developing your temporal lobe, which is where your language, your memory, your audition happens, you're not developing your auditory cortex, the brain goes, hey, we have an emergency here. We need to borrow these neurons, because we need to strengthen our sensory cortex, our parietal lobe, and we need to strengthen our occipital cortex, our vision. So those two senses actually start to get stronger. It's called synaptic pruning. So those parts of the brain get really strong, and that's why often deafness can look like autism if it goes undiagnosed, because they're super hypersensory. So that's important to know. And then they obviously don't have spoken language. So that's why it can look really similar. And that's another thing to note, and we'll get into communication options, I think probably very, very soon. Okay, here we go, because it's very relevant to that. Okay, so let's talk about deaf culture and ASL and this neurological emergency. So, okay, here we go. So it is my opinion that parents do need to make a choice, and they need to make it a choice pretty soon. And again, the reason being is that time's a ticking, and we do need to get access to the brain, because if a child can get hearing, you know, especially if they are eligible for a cochlear implant, if they have severe to profound hearing loss, and they can get their CI by age 1, ideally 6 months, 9 months. I've seen 6-month-old babies, you know, get their CI and go to therapy. I had this one family, and their first child got their CI at age 2. And I was working with him when he was 3. And their second born son got his at 6 months. And the difference between these two kids in a couple years' time was so profound. So the one who got his at 2, you know, was talking, and he was able to eventually have, you know, normal language. He had some articulation, you know, his speech was a little bit off, and he, you know, required some intensive therapy. The baby who got his at 6 months old you could not tell that he had hearing loss at all, and he was just as profound. They both had connexin 26, and the like naturalness of his speech was so, and his listening was so like night and day contrast to his older brother. So it just goes to show how much that time is exponential, how much that time really matters. So CCS is like the California insurance company. It's like our California Medi-Cal, and they just changed their eligibility approval, like the FDA approval criteria, to 9 months, which was really, really exciting because before it was at 12. So parents would like be approved and have to wait until they could have their surgery, even though we know how exponential that time is. So at Stanford, we developed a protocol when a child was referred on an ABR that they, have severe to profound hearing loss, they would immediately have a consult with me, and I would walk them through their options. Now, I had several families who had strong ties to like ASL and deaf culture, yet they were like completely hearing and speaking themselves. So in those cases, I would counsel them like, you can do both. You can do AVT and listening and spoken language and ASL, but it's really important that we like work on the brain, on the auditory cortex as soon as possible and even sooner. So the thing is that you can, like a child with hearing loss can always learn ASL and sign language, and they can learn it pretty much at any point. Because their visual cortex is always available to them and even stronger. So they'll learn it really fast. They'll pick up on it really fast. However, let's say, here's an example. Let's say I ask you a question like in Spanish. Let's say you're learning Spanish and I go, ¿Quieres manzana? And I show you an apple at the same time. And I go, ¿Quieres manzana? But I want you to understand my question, but I show you the apple. Are you actually going to hear and pay attention to my question? Or are you just going to go based on what I showed you? You'd be like, oh, apple, I know what that is. You won't have to hear the question. So it's really important. That's called auditory first, is to go like, ¿Quieres manzana? And then have them process it first before you show. So that's just a layer of having them like stretch their brain and work on that auditory cortex first, so that their brain has enough time to process the auditory information to determine if they knew what was heard, like if they could figure out what they heard before they get the visual. Because if they get the visual, then they just tune out what you said or tune out the auditory information. Does that make sense? Hopefully. Okay. So there's an organization called EDDI, for early detection of hearing loss in infants, I want to say is what it stands for. And they kind of changed their stance recently to be communication opportunities. And it's my experience in the last like 5 years that we've seen a lot of like organizations and educational systems be like a lot more try to be a lot more like inclusive, and like that sounds really nice, but it's like everybody like work together and do the same thing. And so what that looks like, here we go. Let me show you on the next page. Okay. So there's a thing called total communication, and that's kind of in between ASL and auditory verbal therapy and listening and spoken language. And total communication is like where you're signing and speaking at the same time. And however, like on the example I just gave you, you can kind of see the problem with that is that the kids will default to the visual and not pay attention to the auditory because they didn't have to. And so when you're doing AVT and listening and spoken language, you're cutting out the visuals first and then providing the visual support so that they have the opportunity to process the auditory information and really pay attention to the auditory piece so that they can develop that part of the brain first, because that part of the brain is playing catch up. So if we don't maximize that time in like the early first years of life in like our, prime language learning window, then we're really going to miss the boat, and they're never going to get to like the level of their potential in listening and spoken language. So it's my personal opinion, like if parents do want their children to learn to listen and speak, it's really important to like kind of go hard in like the first 0 to 3 years of life on listening and spoken language. You can do ASL as well, but make sure you're doing it in an auditory first kind of way. So okay. And So 90% of deaf children are born to hearing parents. And of that group, unfortunately, it's, let me think of the statistic. I think it's only like less than 50% progress past a preschool language or preschool level of sign language. So what that means is, let's say you are a hearing parent, you send your child off to deaf school to learn ASL. You as a hearing parent are like, yes, we're going to do ASL, we're going to do deaf culture. You start learning ASL and you like get, learn quite a few signs, you get pretty good, but your ASL often like doesn't progress past a preschool level of sign language. And so your child continues to grow, continues to develop, continues to go to deaf school. They have like an advanced vocabulary. They are fully fluent. And yet you are limited in what you can communicate. And they, you have this disconnect and this kind of isolation that happens. Like if the whole family is also hearing, like grandparents, cousins, everybody else, they're not necessarily going to learn ASL at that high level either. So it does create a lot of isolation for the child. That's actually kind of how ASL or how deaf culture was born in the first place, was that's exactly what would happen. Parents would send their kids to deaf school, and the only people they could really relate to was the people that they were with at school. And so that really birthed this beautiful culture. And yet now we have this bridge where people can learn how to speak and how to talk and how to communicate with their families at such a high level, and then also they can learn ASL and be part of that culture as well. So I hope you hear me when I say that it is totally possible to do both, and I am part of this community that believes in that. But it is also, I understand how the brain works and how it is so essential to get sound and listening to those children as early as possible in order for them to really have fluency in listening and spoken language, if that's what the parents want for them. So it's really important to have that conversation really candidly with the parents and gently with them, especially as they're going through this really intense kind of grieving process and tons of appointments, and to be super gentle, but also really make sure that like they're educating themselves and really understand what they're getting themselves into in all areas, like what their decision means for longer term outcomes in every aspect, and try and get to the heart of like what their goals are for their family. Okay, any questions here, guys? Okay. All right. So I think we can probably skip this. Everybody feel confident knowing how a CI works? Everybody raise your hand if you know how a CI works, or yeah, okay. Yeah. Okay. Do you guys want to watch the video really quick? What do you think, Dr. Jordan? It's like a 1-minute video.
Sorry, yeah, unmute. If it's just 1 minute, go for it. They did
Okay.
have Cochlear Americas come and talk to them about cochlear implantation troubleshooting though. So
Oh, okay.
they
Okay.
should know
Okay.
what's up.
Okay. Well, then let's skip it so we can try and stay on track here. All right. And you guys have this PDF of the slides too, so you can always go back and watch it, and you just Google the videos by Cochlear itself.
Yes. And it's
okay.
posted on Blackboard, everyone. So all
Okay,
of the extra resources Kim gave me and the slideshow.
Awesome. Awesome. Okay. So you guys pretty much know this as well. Okay, so this is really important. How many of you have taken like a speech acoustics or speech and hearing class or whatever the heck they call it in your program? Anybody? Okay. Nice. So hopefully you had a good professor. I found mine incredibly boring, unfortunately. It was interesting at times, but the professor was a little bit dry. So it was tough because it was like music majors, which was cool, and like speech pathologists together. And so it was really confusing and interesting at the same time. But I wish I paid more attention because holy crap, it comes in handy in my job all the time. So let me explain how and why that is. Okay, so on the right, of course, we have an audio. So we have aided hearing and unaided hearing here. Okay, so for this person, drop in the chat, please, some of the sounds that they're not able to hear, some of the speech sounds. For Candy on the line. And remember, they can hear everything below the line. Okay, good, Maddie.
Yeah, we're getting some good high
Good,
frequency.
Yep.
Yeah.
Good. Good, Gianna. Awesome. Oops. Okay. Good. Thank you, Dr. Jordan, with the candy. Okay, perfect. Yep. So we're missing all these sounds up here. Now, yes, bummer for this child. So that means let's pretend it's a cochlear implant, which is unlikely based on this audio, but let's just pretend. Oops. Okay. Here we go. Let me move these out of the way. Okay, so let's pretend this is a cochlear implant. All right, and they are missing these sounds. What's more often what I would see is like we're like here, we're 20s and 30s, and we're kind of like across here, and we might like cut here. So we might be missing like F, TH, and S specifically. And that's actually really common because often when we turn on a cochlear implant and people didn't have access to the high frequency sounds before, that they feel uncomfortable at first. So it takes a while to get used to those new high frequency sounds, especially as an electronic signal. It's like almost like that part of the cochlea hasn't really been stimulated before. And so it can sound a little bit like high pitch, or like people will say like a little bit squeaky, or there's like this weird, people will say there's like a little bit of a kind of almost like a psh sound like on top of speech. So it can take some acclimating. And so let's say their aided audio kind of goes like this and cuts off the F, TH, and S. So then my job is kind of to make sure functionally that that's actually true, that they're not hearing those correctly. And then we go over here and I go to their audiologist or come with them to their audiologist and say, hey, can we check? I think we're not getting like 4,000 to 5, basically. So for the F, we're not getting 4,000 to 5,000 hertz. For the S, we're not getting 5,000 to 6,000. And then for TH, here we go, we're not getting 6,000. So I'd say like, hey, is it possible to, let's see what it feels like to them to turn up like 4,000 to 6,000 hertz. And then the audiologist will, determine if that sounds like a good idea. And then maybe we'll turn it up to, to test it while they're there connected. And if they will get it to a level where they can tolerate it, it's not uncomfortable, but maybe they have a little bit more access to those sounds. Or sometimes like what I'll show you with the Ling 6 sound test next, maybe you say, and they say, shh. So you have to determine, okay, they heard my S as an SH. So let's figure out the difference there and see if we need to tweak those frequencies so they sound right to my client. So it definitely comes in handy to understand speech acoustics and how that works. Okay, so yeah, this is basically what a cochlear implant audio looks like, usually between 20s and 30s, depending on your brand. So you can go from, an aided or unaided audio like this in severe to profound hearing loss to, being above the speech banana, which is really essential to make sure that you have access to all the sounds of speech. Now with a little one, like a little baby, we need to kind of determine, Dr. Jordan and I got to do a few of those appointments where I was in the booth with the little one and I was just watching them super intently to see when they turned to sound. So looking for a behavioral response. And sometimes they were super, super subtle. And that would also give me a clue too. Okay, they're super, super subtly turning to this sound, or, you know, giving me like a little confused kind of face. And so then I'm like, okay, it's probably audible, but certainly not loud. So we would maybe make some changes based on that as well, or be able to determine, you know, their audiogram behaviorally based on those subtle responses. Okay, that brings me to our Ling 6 sounds, and I'm sure you guys have heard of the Ling 6 sounds by now. I love this diagram here because it really shows the shape of the speech banana here. And then I have our lovely frequencies for it as well on the right. And if you want this in just like a Word document, let me know, because I pulled those from, gosh, somewhere, and then made sure they were just in a handy dandy little place like this. So you can email me if you want just an actual copy of that. And okay, let's see. I have some videos for you, so I have to stop share in just a second. But when you have a little one, like a little baby, again, you're going to look for those behavioral responses. So like you can have the mom or the parent right there, and then you can like have another parent or the other person, especially if you have a second person, you have one person kind of like in front of the baby and then another person behind the baby, and doing those different sounds. And you're kind of training the baby to associate the sound with a specific toy. So like ooh is the ghost. I'm sure you guys know this. E can be the mouse, ah is the airplane, S is the snake, and SH is the baby. And so you associate those sounds. So when the baby shows a reaction to the sound made behind them, then you show them the sound, you imitate the sound, you play with it, and eventually they'll imitate the sounds. Before the baby can copy the sounds, like speech wise, before they can actually physically make the sounds, they can like grab the right object to show you what they heard, which is really phenomenal, because then you know, okay, they're hearing SH as SH. It sounds like SH to them. They're hearing ah as the airplane. They're hearing as the ice cream. So you know that, okay, the frequencies are like where they need to be. So that helps you determine, you know, if they need mapping changes or not. Like if they never turn to the S, then you're like, okay, they probably need their volume turned up in the frequencies of S. Hopefully that makes sense. Okay. Which is really common. Okay. So some school, let me see. We should see if I can show you a video really quick. Okay. Aha. All right. Okay, so this is a really good video to show you. Hopefully, let me make sure I'm sharing my sound. All right. Okay, and then let me know if you can hear this. This is when I was working at Stanford.
And I can cut this off. Not a big deal. My master editing skills. Okay.
So he showed us a reaction.
Better than before. Have you been testing further away or?
I've been a little closer than that.
Okay.
Just
Okay.
a little.
Good.
Yeah.
Good. Good. You heard that,
The
buddy.
other ones, the other line sounds. He's fine with all of them except.
Raise your hand if you can hear.
He was imitating them before.
Yeah.
So it's not that it was.
Okay, cool.
Production.
Yeah, this was just like even the detection level wasn't there.
Yeah.
So, because then I was doing it in front of him with that guard thing, which helped because it was like engaging him that way. Because then he would take it. Yeah. And then he would make the sound holding it.
Do you want Cheerios?
What do you want?
Do you want Cheerios?
Do you want the hair clip?
Look. Do you want? Okay, I will open. Can I open for you? I will give. Wait.
You can say open.
What do you say? I want.
What?
Want what? What do you want?
One Cheerio.
Okay.
Wow.
You give 4. Generally.
How many?
That's
You heard me. What did you hear? Rishi, can you try? You try? You guys already used this.
He doesn't.
Oh.
It's the full
Can you-
range.
Okay. So that was what we call a co-treat session. So that's the audiologist Jan there, and then that's me, obviously, with the family that I've been working with ongoing. They're a super reliable family. The complaint was that he wasn't turning so much to S when mom and dad had been trying at home, and I wasn't seeing it too much in our sessions either. So before the video started, Dr. Larkey turned up the frequencies of S, and then we saw his reactions a little bit more live in the session. So we're like, okay, he seems comfortable. He turned to it. That's exactly what we want to see. He also turned to the SH. So we felt happy that he was able to hear those. Any questions, you guys? Okay, cool. Back to the slides. Okay, and I'm going to also show you, so I'm going to show you another, while we're here, I'm going to show you another baby session. It's one of the cutest ones. So this is a little girl that I was seeing also at Stanford, and she, I think had her cochlear implants for like 6 months before this session. And so we were just trying to get her to like listen and follow a direction. And we were also incorporating her sister, which is really important in AVT. It's so important to involve all members of the family, because the more like talking time that they get, the better. And often siblings like really want to help, and they just want to like know what to do. So it's really important to involve everybody, so you can get everybody on board, and that, you know, the child gets as much, you know, quality input as possible. And the other reason that I forgot to mention earlier that teletherapy is so successful with AVT had been doing telehealth longer than anybody else for like the last, you know, since like FaceTime was available, because often, you know, kids will get their cochlear implants and live really far from the center. So they'll live a couple hours away, and it is absolutely essential that they get therapy at least once a week at minimum. So, you know, teletherapy has been viable and has been, you know, being used for at least the last 15 years, probably at least the last 20. I was doing teletherapy with kiddos when I was at the Weingarten School back in 2015. So it's definitely got a lot of precedent, because it's so much about parent training. It's so parent training and parent coaching centric, because once you can get the parent to really understand what they're doing, it's so much better for it to be during the natural routines than like in a sterile clinic setting, you know, for 1 hour a week. So that's why AVT is so successful, is because the child can be asleep and like the parent's just getting this full on crash course during the session. But it's also good, of course, if the kiddo can be awake and attentive for it. But if they can't, you know, we're just coaching the parent through, you know, what to work on and what to try that week, and you know, through their successes and their challenges, and just trying to figure out, you know, where their child is and march them forward in their milestones and stay one step ahead of them. So that's why teletherapy is super effective for these kiddos, especially, is because it's all about training the parents and the family. Okay, I'm going to share this video with you. Super cute. All right, let me know if you guys can hear it. Please raise your hand if you can hear.
There's a lot of good stuff.
Let's listen to Avery now.
Yes, you can ask her to play something.
Okay, cool, good.
Yeah, so say, hey, we're gonna clean up. Can I have your necklace? Maybe we're gonna.
Sorry, it's a little quiet.
Can I have the necklace?
Take this side to stand so she can see. Is the necklace in the bag?
And then maybe ask her for something else here.
So can you ask for something else here?
Maybe.
And then she signed keys. Good. So that is one of the families that worked really hard to do sign language and listening and spoken language. So what was so neat with her is that she could, before she could speak, she could sign back what she heard. So that was super awesome. So she said, "Can you give me the keys?" And she signed keys.
Bye-bye, keys. Put your keys in the bag. Good, listening.
Awesome.
That was perfect. Fake us out. Try again. You want
We're getting ready.
Good job.
May, can you put the bunny in the bag? Can you put the bunny in the bag?
Okay. You have the small phone. Put the small phone back in the bag.
Put the phone in the bag, May.
Clean up.
We're cleaning up. We're gonna say bye-bye.
And put the little phone in the bag.
Bye-bye. Clean up. Shake, shake, shake. You're saying I'm not done playing, and I'm tie-tie. Oh, say goodbye.
Put your phone in the bag.
Yeah, say bye-bye.
Thank
Good
you.
work, May.
What else can we clean up? Oh, yeah, we're done.
Yeah,
Can we clean up the bunny, please?
a little bit more. Bye-bye.
Thank
I understand.
Put
Can
your
we have the
CI on.
bunny?
Hop, hop, hop.
She said, "Hop, hop, hop" for the bunny.
Can you put the bunny in the bag?
Hop, hop,
Still
hop
yours.
your bunny into the bag.
Bye bye, bunny. Bye
Thank you.
Nice.
Can you put
Bye bye
bye
glasses.
bye glasses? Bye bye Jessie. Bye bye mirror. Bye bye sticky tape.
Okay,
Bye
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 bye.
May. Do you know the bye bye song? Yes. Do you want to sing it?
Yeah.
Bye bye May. Bye bye May. Bye bye May. We're glad you came to play. We'll see you again next time. Yay! Good work today. Bye bye. That's my watch. That's my watch.
Hmm. Okay, super cute, right? She's adorable. I miss her. She yeah, it's one of those cases that I mentioned where mom like had, I think it was, she mastered or majored or minored in ASL in college, and I believe had a cousin or sister who used sign language as well. So it was important to their family. However, she also wanted her to be able to do listening and spoken language. So they were one of the families that I counseled, like, you can totally do both. It's just going to be a matter of kind of working double time a little bit and making sure we do auditory first so that she is getting the auditory input and then is able to process it before we come in with the visual. So you saw it be super effective there, where we said, put the keys in the bag, and then she signed keys and then was able to do it. So that was super, super awesome to see for that family. They were so cute, and she's doing super well. Okay, so that was some baby therapy. Let me get back to the slides for you guys. All right. Here we go. All right. And again, feel free to take yourselves off mute if you have any questions that come up, okay? We've got just a few more minutes. I'm going to go a little bit quickly, but you will have, like, there's some slides with goals on them, and you'll just have these. I won't read the goals or anything, and you'll just have them for future reference, okay? So that was our Ling 6 sounds, school age considerations. Really important to empower parents here, because so often they will, like I said, a lot of programs have condensed. Like this happened in San Diego recently. They used to have like a listening and spoken language school called an auditory oral school, and they had like a total communication program. and then at like kind of a school for the deaf program. And in the last 5 years, they can collapse them all into one. And so I have a lot of families that are going through like lawsuits and litigation right now because their child is not getting like appropriate services based on the goals that the family set and based on what they said that their desired outcomes were. So they're saying that they're like not getting an appropriate education based on what their like family goals are. And so and what's possible for them. So they're like, I have one family that's getting what's called compensatory education. So they're getting my service, private services paid for by the school district because their argument was that the school didn't provide the services that they said they were going to provide because they collapsed them into this other school and truly didn't provide the services that they said they would. So all that to say, it's important for parents to be like empowered and know the law and know what they can ask for. Because often, especially with my Hispanic families, I see it so often, it's like a cultural thing to be like, hey, you're the professionals, you know what's best, we'll just accept what you give us. And in fact, it's really important for parents to understand how to know how to write goals, how to know what the goals that they're working on are, what's an appropriate 1-year goal, because that determines the level of service, the amount of services that they get is what goals that they're working on. And it is important for the families to know what's appropriate to expect and developmentally what their kid can achieve in a year. So it's really important that parents are empowered that way. Often districts will try to offer limited services due to budget cuts and lack of funding. So it's important for families to know how to advocate for themselves because the districts can find the money and they can advocate and allocate appropriately based on what's needed, or they can pay for another program or some outside therapy because you don't get that time back. Kids don't get that time back. All right, so there are some programs in California, some examples here. So it's important to know what's possible. Oh, shoot, on one of my versions of this PowerPoint, I had programs in DC, but unfortunately I don't know where that version of the PowerPoint is. So here we are. Okay. So it's important to know how an evaluation differs when there's hearing loss, that you need to include a listening portion so you can assess what the lingering 6 sounds. There's an evaluation called the functional listening evaluation, FLE, which is actually fairly easy to administer. You can get it online and then it pretty much explains how to do it. So if you're giving an evaluation in person, I highly recommend that one. And it's important to do repeating sentences at 20 feet. When you saw, I have a bunch of speech hoops. Speech hoop is that screen that goes in front of your face. So at first, when I was first introduced to those, I was like, that feels kind of cruel, making a deaf child not be able to see your face. But it makes so much sense to me now because you have to determine what they can actually hear. And so you kind of do that, see what they hear, and then you can show the visual. So it's like that auditory first thing I showed you earlier, and it's training the brain. So if you give the visuals at first, they're going to be amazing lip readers, and they are going to be amazing lip readers by default because there's background noise and there's challenges, and even people with cochlear implants are still operating with a mild hearing loss usually. So it is really important to know what they can hear without visuals. Okay. So red flags for hearing loss: speech and language delay, difficulty with listening and attention, difficulty specifically with high frequency sounds, behavior challenges and frustration. And what do? We refer to audiology for a hearing test. You do a hearing screening if you can, but when in doubt, refer to audiology. Okay. Oral rehab therapy. You may have seen this pyramid before. So we start with detection, knowing if there was a sound, and then looking for those responses in the babies, like I told you about. Discrimination is knowing the difference between sounds. So for example, discriminating between familiar voices and unfamiliar voices, or knowing the difference between hearing the difference between cat and car would be another discrimination example. Identification is what you saw in the purse activity. Put the bunny in the bag, and then she had to identify bunny. Comprehension is following directions. So even at like a little bit of a higher level, understanding the direction, understanding conversation. And that's like step 4. Okie dokie. So this is what a speech therapist works on with a cochlear implant user, whether or not you're an AVT. Like often you'll have, you know, one or two kiddos in a school district that have cochlear implants that are not seeing an AVT, and maybe there's not one available. So it's important to know what the heck to work on. So these are some things to remember, working on listening first. So like, even if a child has, you know, looks like articulation problems, you need to make sure that they can hear it first. So that would involve like covering your mouth and making sure what they're repeating back. You rule out an articulation error versus a listening error, but that they're repeating back, you know, that they mark the sound. So for example, sometimes you're working on like an F sound and you'll say like, and you'll cover your mouth and they'll come back with like a S. So you know that they heard you, but it's not coming out right. And then you'll have to figure out, okay, can they make it when I show them the visual? Can they make the sound? And so if they can make the sound, then okay, then it's they heard it and they can make it. Now it's an articulation thing that we work on. It might be a little bit confusing, but you have to make sure that they can hear it first. Then also to think about articulation, I would not work on articulation yet if they can't follow a 2 to 3 step direction. So that's like a 2 to 3 year old skill, is following a 2 to 3 step direction. And if they can't follow that, that means they don't have enough auditory memory to hold on to information. And if they're in school and they're like 5 and 6 and they can't follow a 2 to 3 step direction or remember, you know, 3 key words in a direction, then don't work on articulation first. You need to work on those directions, because that means that they are not retaining anything that the teacher's telling them. You have to grow that auditory brain like as first priority, because the more auditory memory they have, the more they can retain information in class, and they'll, you know, their vocabulary will improve and all kinds of things. So typically people with hearing loss have a lower vocabulary for a few reasons. One of the reasons is that their listening bubble is smaller. Most kids actually learn most of their vocabulary through incidental learning, like over 75%. Incidental learning is like overhearing and kind of what happens in the background. So when kids don't have that because their listening bubble is smaller, then most of their vocabulary has to be what's directly said to them or directly taught to them. So that's why their vocabulary tends to be a little bit lower. So we're working on vocabulary, we're working on self-advocacy, because that all wraps in. They need to know how to be able to ask for an unfamiliar word. What was that word? I didn't understand. Can you say that again, please? Repeat, please. All really, really important social skills, especially for kids with hearing loss, especially for their peers, because if they don't know how to do that, they'll just like smile and nod and feel super isolated. Okay. Often, yeah, you'll see those grammatical errors, excuse me. Okay. So, yeah, really important to coach the parents to recognize, as you're working with babies and toddlers, that the parents really are your clients, almost even more so than the babies and the toddlers, as cute as they are. So really important that parent coaching is first, that you're teaching them strategies like auditory first, and there's strategies called auditory sandwich, which I gave you a handout in your resources on how to do that. Utilizing their routines, how to like maximize vocabulary stimulation during their routines is so important. Often it's a lot of repetition and acoustic highlighting. Like, let me think of an example. Like, oh, let's go do some laundry together. Go get your shirt. Where's your shirt? We need to get your shirt. Help me find your shirt. So that's repetition, really highlighting that word shirt to make sure that they got you, that you're, you know, kind of focusing in on that vocabulary word to see if they understood you. If they didn't understand you, then you're at least teaching it, right? So that's what acoustic highlighting and repetition looks like. Often, okay, when will they hear their first word? That's a question I get all the time. like when will my baby say their first word? And it's usually, if they've had like no language stimulation, then it's usually 12 months after their like listening birthday or their activation day. So if they get a cochlear implant or they get hearing aids, then it's usually roughly 12 months after that, because they need, you know, babies typically say their words at 12 months. So you kind of start from that day that they get their hearing going and then count from there. Okay, 12 months. That's when their language age or their listening age is roughly on track with developmental milestones. Okay, some goals. I won't go over these. You'll just have them if you need them. Feel free and email me any questions. Determining progress. So we were just talking about listening age. It's like the age since they were able to hear speech above the speech banana. So often it's CI activation day. If they're, you know, just have hearing aids and they're able to get up top of that speech banana, that's when you calculate from, versus their chronological age is their like actual age by their date of birth. And then their language age is like an estimated age of their language skills. So like they can be functioning at a 2-year-old level relatively. And then it's also important to determine rate of progress. So for example, I have a 7-year-old now who had a 3-year-old language level last year and now has like a 4 to 5-year-old language level. So I'm like, okay, we're making 1 year of progress in roughly 1 year's time. So ideally we want to go faster to try and catch up to her age of 7 years old. So what can we do to speed up her rate of progress? Does that make sense? Okie dokie. Any questions so far, guys? I know we're running out of time here. Okay, this is what we work on with school age kiddos, auditory memory. So that's like the keywords in a direction like I was talking about. And I'm sure you guys have heard about auditory memory. We work on FM, advocacy, and independence. We work on reading, vocabulary. So reading is so important because it ties in with grammar, with vocabulary, with everything. So the more that they become good readers, the better their vocabulary gets. So really important. Here are my favorite apps. Just to know that you have this in this PDF so you can remember. My favorite physical games are Headbands and Guess Who is super good. Headbands is great for teletherapy, like gold for teletherapy. What else? Like the Little People, you know, like the little Fisher Price Little People. Those are super good for auditory memory. And yeah, I often have like, we play like bingo on my screen. But it's often about like the games that the parent has at their house. So you ask them in one of your first sessions, like, oh, what games do you guys have? And then you, you know, have them bust out their games and you like guide them through it, whether or not you have that game. You work with what they've got and then have them play so that way they can carry it over during their week. Okay, tons of goals for you guys. More goals. Okay, this is for teens and adults. This is the communication corner from Cochlear. It's a really good program. They also have like a telephone with confidence. There's a whole like basically a binder worth of materials that you can print out. They do work well for like older teens and adults. This is my favorite program for adults. It's called Sound Success and it's in abrehabportal.com. And you can really give this as homework and you can also kind of determine their level. So like, for example, with this one, the computer will say like, the long coat is $55 and then they'll have to like click through. Does that make sense? Based on what they heard. And you can turn the video on and off so it can just be auditory only. You can add a little background noise. You can change the speakers. This lady is the best one. I think her name is Patty. But there's different speakers that you can use. Super great program. I use it for teens as well. And it's free. Okay. Co-treat. We talked a little bit about co-treat. You saw that video of the little kiddo having a co-treat because he had a Ling 6 sound error. And for older kiddos, you can do like syllable testing, so you can test all the different consonants. There's a thing called the medial consonant test, Iowa medial consonant test, and it has all of these like consonants with the different vowels. So you can do that test and then determine their errors, and that would be, if they have quite a few errors, that would be a reason to call for an audiology visit. Okie doke. That's me scrubbing in for a CI surgery. That was a really cool day. And yes, these are my favorite websites. Really, really, really good resources. Success for Kids with Hearing Loss has so many good assessments and free resources, and a really good place for parents to know about IEP accommodations. JohnTracyClinic.org, so good. Tons of really good Spanish resources and handouts. HearingFirst.org, they have a podcast. They've got tons of great videos for parents. Super awesome. They're really closely linked with AG Bell. And then Hands and Voices is really good for people who also love sign language, and it's great for ASL, total communication. They've got a lot of like local chapters that parents can be a part of, which is really cool. They've got like 5Ks and all kinds of community events as well. Okay, I know we are so over time, you guys. I'm so sorry. Okay, anyone have any questions? That is the end of my presentation.
I am hearing silence.
I
So
know.
I will take that as no questions, I guess. Everyone, Kimberlee Ramirez, MA-CCC-SLP, LSLS, Cert, AVT. What a mouthful. No, I love it. You managed to keep everyone on for the full time. So way to go.
Oh, thank you, Emma.
I know.
Thank you. Thank you
if
guys for your attention, for your time.
If anyone has questions, Kim's email is right there. Feel free to email her.
Yeah. Yep.